Well, one of the highlights of the Critical Care Congress are the abstracts. This year we saw a record number of over 2,500 abstracts submitted and almost 2,000 accepted. Abstracts are published in Critical Care Medicine, the #1 critical care subspecialty journal, and many are being presented as part of the Research Snapshot Theaters. We're happy to go now to the exhibit hall and speak with two young professionals who are both presenting here their abstracts at Congress.
Aloha everyone, this is Tony Gerlach again with some of our abstract award winners. This year at Congress we saw a record-breaking amount of submissions of almost 2,600 with 1,981 accepted. And I'm with
Anthony Sochet. I'm a pediatric intensivist from Johns Hopkins All Children's Hospital.
And Alistair Johnson. I'm a PhD at the Laboratory for Computational Physiology at MIT.
So I know, Alistair, this is your first meeting, and this is your second meeting, Tony. Can you guys what you think of Congress so far and what you're looking forward to seeing?
What I think of Congress?
So far, the ones you've been to.
Yeah, I think this is an opportunity for pediatric intensivists and adult intensivists and people who work with critically ill patients to get together and put concepts together that they wouldn't necessarily have an opportunity to unless they meet at meetings like this for collaboration. We meet people from basic science, back in the laboratory, all the way up through translational science to PhDs who are doing computational math that I will never understand. And you may have a research idea that you would not have otherwise been able to accomplish or even think about without hearing someone else's process and thoughts. So this is a great opportunity to do those things. I'm personally looking forward to doing some of the bigger plenary sessions regarding alternative ventilation, which is an interest of mine. But the other sessions are also equally as important.
Yeah, it's a fantastic meeting. It's very, very big, which I think is a great advantage because you just get the opportunity to meet so many different people who all have different backgrounds and different perspectives on your issue, and that kind of feedback normally takes 3 months in a journal submission, and here you get it over 2 days. It's amazing.
Oh, I completely agree. I think that's one of the reasons I love to come to Congress is the networking and meeting people outside your respected areas. Is there anything from this meeting that stands out from other meetings that professional meetings you've attended?
Well, for my particular field, there aren't as many meetings in general for pediatric critical care, and this really gives us an opportunity to come together as a society and share our knowledge and share our concerns also for how we practice and how we can do it better. And it really does give us a great opportunity, like I said before, to just meet with other fields and see how we can also take it a couple steps further and look to the future for better data, better outcomes, better ways to take care of critically ill patients.
Yeah, I think it's certainly a very well-regarded meeting, and because of that, you get the premier experts here, which can be a bit intimidating when you're presenting, but it's worth it at the end.
Oh, completely. And you know, you never know who you might be talking to. Yesterday I was talking to John Alberti and didn't really even know who I was talking to, and realized you're doing this plenary session. I can't wait to listen to it. So, and it's nice to meet these people who are willing to help people in training and help mentor you along. So completely agree there. Now I hear you're both in the in-training section, correct?
Yeah, I finished training this last year, and I just started my career down in St. Petersburg after leaving DC for fellowship. And I got a master's in clinical and translational research, and working on several projects at once, and trying to get funding and to get other ideas from other people about how I can answer questions better and questions I've never thought of. So that's why it's important for these type of meetings to occur, and really important to get out there and just go to meet and curbside as many people as you can and get some feedback.
Yeah, the same. So after my PhD, I'm training to sort of learn the language, the medical language that takes some getting used to, and there's quite a lot of difficulty in communicating at first, which is why it can take some time, but I'm starting to get into the swing of things.
Awesome, I'm glad to hear. So Tony, I hear you have a couple of abstracts here, and you're part of the highest award-winning abstract. So can you tell me a little bit about it?
I've had a great opportunity this last year and this year to present some data from not only fellowship, but also data that I'm starting to collect at my new institution. And The two abstracts that I'm personally presenting are looking at the safety of using non-invasive ventilation in children, in the sense of, is it safe at all to do it, or should we just be intubating patients who come in with respiratory distress? It's a question that many intensivists anecdotally have very strong opinions about, but there's actually limited data to really suggest what's the best outcome. So we looked at every child in a year that was intubated for bronchiolitis in our institution, and 40 out of 350 were intubated. And we looked at, does the time delay to an intubation predict a worse outcome? And in fact, it does not, including mortality, several comorbidities afterwards when they leave, cost. And so it's a simple study that said, hey, go ahead and try it, why not? But more data needs to be done for that. And then I have a second study that looks at surgical site infections, and particularly looking at fluid overload after cardiopulmonary bypass, to see if a pharmacokinetics analysis can be done to say, if I give you hundreds of cc's per kilo of extra volume during your postoperative period, perhaps the dose of antibiotics that we're giving you is not actually what we think it is. And it turns out that being fluid overloaded absolutely predicts having a surgical site infection. And so we have some work to do to figure out how we can better deliver care to the kids in that period.
No, I think that's good, and as a pharmacist, it totally makes sense to me. And now, Alistair, I think yours is on the sepsis 3 definition, which was a big buzz of last year's meeting. So can you tell me a little bit about your research?
I hope it's as interesting as Tony's. So yeah, the sepsis 3 guidelines sort of made a splash last year, and at MIT we have quite a unique resource in that we have an openly available critical care database, which we can evaluate things like new definitions. So we set out to do exactly that, and we found some interesting relationships between what the guidelines say. There are 3 or 4 different scores, and for predicting mortality, we found that they roughly fell in line with what the guidelines said. And then we went a step further to add a new point to the discussion, which was comparing it to the older validated definition, which used administrative data. And we found that the new definition of sepsis, so to speak, is quite different than what we've been evaluating for the past 10 years to study the epidemiology of sepsis. So I think it raises some questions on where do we go from here? We should maybe slow down and actually think critically before we completely redefine everything and make sure that we're always comparing, apples with apples.
Right.
Well, no, and I completely agree. What are we looking at? What we think we're looking at is always the number one question. And you guys bring up a good point. Is it's just not us, but it's everyone. We have to get everyone involved: the intensivists, the pharmacists, the nurses, the PhDs. Sometimes it's even veterinarians. And I think that's one of the nice things about SCCM is it brings everyone together to actually improve our patient care. But thank you very much for being here. Thank you for listening to me again, and mahalo.
Mahalo.
If you're thinking about submitting your own original investigative research or case reports for next year's Critical Care Congress, you can visit sccm.org/Congress for more information. Abstracts may be submitted from May 4th until August 3rd. We'll be back right after this.